There we go.
Greetings, everyone, and welcome to our 15th Intergenerational meeting. Today we have speakers with us, Dr. David Barron and Dr. Eugene Koh. Today our topic is global sports psychiatry, and I think this is a very interesting topic because I guess it's one of the lesser known area of mental health care. So personally, I'm very excited to hear our speakers, and I would like to leave the ground to our speakers.
Yeah, thank you very much for the very quick introductions. I guess, Dave, I would just go ahead and start first and maybe talk about 10 to 15 minutes about this particular topic, and we see where it goes. Feel free to, again, to ask me any questions and stop me, and then we will see where this talk will actually go to. I did not prepare any slides because I find that if I have some slides when I talk about this, I end up trying to tell people about athletes and sports and all this. So I'm trying to avoid this. Instead, what I'm going to try to do in the next 10 to 15 minutes is to point out why athletes or people involved in sports are uniquely enough that we would actually want to consider it as a separate field, why there's actually some psychiatrists who went on to take up this special interest and to dabble into it. Maybe talk a bit about my own services within Malaysia, the country itself, and also to talk about how exercise and sports are related within mental health itself. Very briefly, because this is a very huge topic, and within the limited time, we see what we can do. So, athletes, why do we actually need to bring this up? Why do we actually need to consider athletes as a separate population? One of the main reasons, and I think this is always very common, if I were to ask anyone here, if I were to ask you now to imagine an athlete, an Olympian, someone who's competing in the Olympics or any other national main games, what's the image that would come to your head now? If I were to ask you to imagine an athlete, chances are you're probably going to imagine someone who is very well built, someone who has top physique, someone who is focused, highly trained, highly motivated, so on, so forth. These are usually very positive qualities. And when someone represents a community or society in such pinnacle, such high levels, we seem to put them onto a huge pedestals, and we often forget that these athletes are, at its very core, human also, which means they are equally as susceptible to mental health conditions. They are equally susceptible to the struggles, day-to-day struggles that you and I all have. But we often forget that because of the way athletes are being portrayed, being seen in the media, and this is one of the major things. Conversely, when athletes have issues with mental health, they are very reluctant to come and seek help to a degree, because often when they come and seek help, or it would mean that when they have a disorder, they can no longer be an athlete. They might not be able to perform as what they require within as an athlete itself already, and that could jeopardize their whole career, their whole identity and livelihood itself, which makes them one of the least likely to come and seek help. And any mental health work that is to be done for athletes, ideally, not to say all, but ideally should be done from a primary prevention level. Get to them, educate them, and kind of address some of the issues whatever issues that they have at the very beginning before it actually sets into a tertiary prevention or secondary prevention. On top of that, as I mentioned, because athletes are top levels, they are required to function, they are expected to function within high levels. The needs, their mental health needs would be very different from our regular clients or patients that we see within our outpatient clinics. These are people who would probably be affected by different things. I can't do my sports now, my identity is going to be affected. When we talk about trauma, we're not talking about life-threatening trauma. It could be an injury that they sustain during training or competition. To them, that is trauma. They will experience symptoms that's similar to PTSD. They don't have substance use disorders. They don't abuse our street drugs. but they might get in trouble with some of the substances.
Sports now, my identity is going to be affected.
For instance, such as doping. They might struggle with these things. So their manifestations within athletes itself are different, and these are things we don't cover. These are things we don't talk about in general psychiatry.
Greetings, everyone. Welcome to our 15th Intergenerational meeting. Today we are with us Dr. David Barron and Dr. Eugene Ko.
Shannon, was that me or someone else? Yeah, sorry.
Sorry, we had a problem, but I think we fixed it now.
Yeah, we had a bad look. Anyway, as I was saying, so athlete itself is a very separate population that requires certain skills, additional training, additional education in order for us to effectively work with the mental health of athletes. And on top of that, this field itself is rather new. It was formally created or formalized within the last 20 years or so, and only in the last 5 to 10 years, we start having more and more advocates. We start having more and more people talking about it. I believe Dr. David himself was recently in the Beijing Olympics as a sports psychiatrist to represent the United States. This is new. This is something that are gaining traction, and I believe that in the very future, this particular field is going to grow even more, and we're going to have more and more representatives. There's going to be more and more work that's going to be done for this. So that is the first part when I want to talk about sports psychiatry, which is the athletes, why they require us to go in to dabble more with regards to their mental health care and related matters. The other thing about sports psychiatry that we look at is actually the use of exercise and sports within mental health care itself. So I'm not talking about athletes. I'm talking about prescribing sports and exercise in order to use as an intervention for mental health conditions. And this will also fall within lifestyle interventions. If we look at lifestyle research with regards to mental health, there's a few things that will commonly highlight. Exercise, sleep, diet, alcohol and substance use avoidance, and the last one, to a certain degree, mindfulness practices. These are common lifestyle practices that has been talked about and has been said that very effective in not just primary prevention, even in tertiary treatment, tertiary interventions for people with mental health conditions. They are effective. There's evidence, there's ample evidence saying that sports and exercise are useful within the context of mental health conditions. But yet, at least within my setting, within the LAMIC setting, because of time constraint or perhaps because of even lack of awareness, these things are not prescribed as much as it should. And I think that as someone who's interested in sports psychiatry, I think this is something we should advocate for. This is something we should always talk about. And right now, even my own practices has changed since I came into this field already. So my trainees, my students are required to always consider, is there a possibility of prescribing exercise as part of an intervention for any mental health? So if I have someone who's, let's say, coming with depression, our intervention plan is not just biological, your medications, it's not just psychotherapy, it's not just looking at the social, we actually include what can you do in terms of exercise and sports. And we don't follow WHO's guidelines of X amount of minutes per day and all this. We actually say, what can you do that within your current setting, can we do it more regularly? Very often when we find that patients who are able to do some of the sports and exercise, their condition actually improve. Their condition actually feel much better. And we do have some theory also. If we look within the psychological intervention, behavior activation requires someone to do more and more activities that brings a certain meaning to them, and so that they could come up with some of the mental health condition. And sports and exercise is particularly one of these. So I've spoken for about 10 minutes already. Dave, would you want to add in any more things that I might have missed, that I grossly missed any points or anything with regards to sports psychiatry as a quick introduction?
No, maybe just to highlight those. So people ask me, why sports psychiatry? Because they've heard the term sports psychology, which has been organized for a much longer time. But I tell them, we have geriatric psychiatry. Why do we have that? Well, because elderly people, although they share a lot, they have some unique issues, both biological and psychosocial. And as Eugene said, this is what we see in athletes. So in fact, in 2003, when the World Psychiatric Association established a new section, it was the section on exercise, psychiatry, and sport. So literally, this is our 20th anniversary this year. And there's lots of data that demonstrates what the biology is of a regular, enjoyable exercise program. We did this study a number of years ago in cancer patients, and that if people go out and they enjoy going for a nice walk, or they enjoy gardening, or they enjoy just getting out, getting that heart rate up, that's actually quite therapeutic. If you tell them to do something they don't like to do, it's nowhere near as effective. So there's clearly a biological and a psychosocial. Why I think this is important is that it used to be in the past, sports psychiatry was like, you have a marquee athlete come out and talk about their battle with depression or anxiety or substance abuse. And that's what the early work was. It was almost like a show and tell, and there was very little, if any, science behind it. Well, what's happened over the last really 2 decades, but really more importantly, over the last probably 5 to 7 years, is a dramatic increase in understanding the biology. So why is it when someone has multiple concussions, they get irritable, they have mood disorders, they get impulsive, they start looking like they're very, quote, psychiatric. So this is where I think we see this interface between biology and psychosocial. And as Eugene so very nicely pointed out, athletes have their own unique stressors, in addition to the fact that they are probably not quite the same as most of us who are not elite athletes. Their biology is different. When I did doping control for many years with the IOC, we had a very difficult time. We used to use the testosterone epitestosterone ratio in testing. And it turns out that you really can't use that in women because they are endocrinologically a little bit different than the normal woman. So I think this field is one that is, as Eugene very nicely said, it's in its infancy, it's growing. And now we're getting more than just former athletes who want to stay involved with other athletes, but the science, and we're learning about this. We're learning about the role of sleep and the lymphatic system. We're learning about why is exercise an important intervention in mood disorders and anxiety disorders. Why do we have exercise addiction? We see this in a lot of our eating disorders patients. So what I think is exciting, and the goal of this is looking at it globally, because each culture has I was so impressed when I had just a wonderful opportunity to spend a good deal of time in Malaysia this past year, is literally going to a Tai Chi class with a group of senior citizens, even older than myself, and just seeing how their movement, it was rhythmic, but they put every joint through a full range of motion. And they got together. And afterwards, they sat down and had tea together. So it was truly biopsychosocial. And I remember seeing this the first time I went to China, which is quite a number of years ago now, back in the early 90s. And then actually even before that, for the earlier Beijing Olympics. And this is something that I think we need to consider. And not that not every young psychiatrist is going to become an expert in geriatric psychiatry, but they all should know something about it. And I think that's what we're going to do, and understand exercise and sport are very much culturally determined. You know, in some cultures, I hate to say it, but it's still this way that, you know, it's almost looked down upon that women should engage in that. Now, to me, that's just horrific that exists. But we don't need to get into a political discussion, but we know there are countries in this world that women, it's really not acceptable, which I think really the WPA should take a very firm stance on that. This isn't good health. When we talk about quality of life, enjoyable exercise, whatever it might be, dancing, it doesn't make a difference. It's getting that heart rate up, doing what you love, can play a critical role in quality of life. And I think we're just now starting to appreciate how important a regular, enjoyable exercise program is throughout the life cycle, whether it's in young children who maybe aren't gifted athletes, they just want to go out and play around. At the NFL, we got them to put a lot of money into a program in the US called Play 360. We're encouraging all kids just to go out and play an hour a day, whatever it was, but just play. And I think this is something that from a global perspective, as a WPA section, which we all are part of, psychiatry, medicine, and primary care, the sports, we should be looking at the role of exercise and enjoyable sport as part of healthy living, as part of increasing the quality of life. And then for those who are interested in working, because there's a lot of politics in working with professional Olympic athletes. Eugene and I have run into this. I've been dealing with this since I first started working in the field in 1975. So I've had a few years working in this. My dad and grandfather were both sports psychiatrists. So even though the formal field's been around, people have been dealing with this for a long time. So I think we have a wonderful opportunity to engage our young people on the group to say, how should this fit in? And Eugene really said it. We should consider this as another tool in the toolbox, but we should absolutely be considering this when we're dealing with any mood and anxiety disorders, sleep disorders, so that we get educators, ask the right questions, research it, and then use it to allow ourselves to be more effective clinicians, consistent with the cultural norms. So let me stop there and let's open for some questions and comments. Probably spoke too much, but at least to lay down the groundwork.
What popped into mind was actually recently I was asked, not by students actually, I was asked by psychiatrists, what sets us apart from your day-to-day run-of-the-mill psychiatry, because we are still looking at the same conditions. And I distinctly replying to the person who asked me this. Both of us are psychiatrists. If I were to give you an athlete with major depressive disorder, you will be able to diagnose the depression. You will probably say the same thing, let's start on the antidepressants. I'm going to tell you, is the antidepressants going to be affected in terms of as a banned substance? It's going to be considered as doping. I'm going to ask you, when he is on antidepressants, is it going to affect his current training in his sports? I'm also going to ask, why is he depressed now? He's probably not depressed from your chances are it's not run-of-the-mill, loss of something. It could actually be related to the sports. And what about the sports that you understand that kind of perpetuate? These are questions, these are things that pop up in the process of actually when we talk to athletes, when we deal with mental health issues. That's not run-of-the-mill, that's not actually in day-to-day. And this is what it sets someone who's into sports psychiatry apart. And to talk about David, again about David, about what he said just now about, exercise and all these things. Every student, every psychiatrist is going to tell you, yes, I know exercise is important, but it's not being prescribed. It's not being incorporated as part of intervention. It's not being advocated. We might say, I do exercise like what WHO do, X amount of numbers, minutes per day, per week, so on and so forth. That one everyone knows, but it's not actively being prescribed or talked about within a tertiary setting, within a primary setting. These are things that we don't advocate. And I feel, and I highly agree with what Dave just now mentioned. Moving on forward, that one of the things that sports psychiatrists have contribute within the global setting is to kind of encourage and advocate for this more. Look at lifestyle changes, because these are low cost, highly effective, very easily done intervention methods for mental health. I'm not even talking about mental disorder, but for mental health well-being. And moving on forward, this should be something that is emphasized in training, in education, and also in clinical practice. Yeah, maybe perhaps if I leave it open to the floor, anyone has any comments or any questions or anything for those who are in attendance.
I'll say a few things if that's all right, Eugene. Just very briefly, I wanted to utterly support what you and David were saying about the importance of exercise, both for kind of mental health promotion, prevention and treatment, really. It's kind of almost the best thing that we've got. And so we don't use it nearly enough. And it's not used properly in primary care as an intervention. It should be in every what they call teachable moments in every primary care consultation, really, the value of exercise. The second point I wanted to make was, I mean, I don't have much experience of sports psychiatry, but I can remember one or two patients who were athletes who I felt were male athletes, who I felt were bordering on anorexia, really. And they weren't paying proper attention to their nutrition. And I felt they were depleted of important vitamins and minerals because they were following some kind of extreme diet for their rather extreme exercise, So I think athletes can be vulnerable nutritionally unless they look after themselves properly. And and that's an aspect. I think we psychiatrists don't always pay enough attention to good nutrition, and that kind of matters. The third thing I just wanted to say was really a kind of highlight from Zanzibar. They realized that their population looked up to their footballers, who they're very proud of, and they're always very cross they can't compete separately from Tanzania mainland in the World Cup. But anyway, they use these footballers as role models for the school children, in not doing drugs, etc., exercise and so on. And that's also can be quite powerful as a mental health promotion message, I suppose. So that's all I wanted to say.
Two excellent points. One is the vulnerability, and I've seen this over the years, like 40 years, that they're all looking for that competitive edge, and sometimes it can be healthy, and sometimes not. Sometimes there are people who have vested interests. This is why doping issues. The key of doping is safety of the athlete, fair competition, integrity of sport. So you're spot on why we need good data, because athletes are very vulnerable, and they're fed like, oh, doctors are going to tell you that. They don't really understand what an athlete really needs and wants and does. So that's a terrific point. And the other points that all excellent points, but this idea of using them as role models. I can tell you, so I've worked probably 8 Olympic Games now, most recently 2022 in Beijing. Nothing I've ever done, even though I couldn't work as a sports psychiatrist because it didn't exist when I started working in the Olympics in '84, and then quite a few since, Barcelona, Athens. But if Michael Phelps or Suzanne or Biles, and there are many international athletes, if they can get up and say, it's okay to not be okay, athletes look to them because they have a very, it's like, whatever credibility I might have in the field, I probably got it not because I was a psychiatrist, because I was a former member of the national team. So I had some athletic accomplishments, whether they were valid or not, but I was viewed as one of them. I know what it meant to not do your personal best or to let your teammates down. And a lot of people who are athletes feel like, people don't really understand what it's like. So I think your point is one that has really been a very critical one, and we need to use more. Is it's not what we teach, it's what our athletes and our students learn. And fortunately or not, the reality is if a big name football player, and I'm talking not US football, but global football, what we would call soccer in the States, or a rugby player or a cricket player or a badminton, whatever the sport is, if a marquee name gets up and says, you know what, this is important, good sleep, exercise, it's okay to not be okay. COVID, that might be the only silver lining of COVID, is it got everybody to realize that, you can be anxious and not crazy. You can be depressed and not crazy. You can have children who are in isolation and adolescents who are in isolation. Really, they didn't have psychiatric pathology, but they knew what that was like. So I think you're absolutely right. And what we need to do as psychiatrists with our patients, particularly adolescents, I found this much more so with adolescents and younger athletes, is to utilize someone who can give, but we need to make sure they're giving the right message. I've seen some athletes who are terrific, and I've actually seen some athletes who've done really some harm on what they've done. So this is why we need to work together. Psychiatry, like sports, is a team event. We need to work together respectfully, as we're experts in mental health, but we're all trained physicians before we ever became a psychiatrist. We need to work with our primary care colleagues who oftentimes have more direct interaction with the athlete, with their families. And this is what I think sports psychiatry is all about. It's about collaboration. It's about working with all of our colleagues. It's about using all the resources we have available. And your point is spot on, Rachel, of, who are they going to listen to? Coaches, trainers, other successful athletes, teammates. And that's why every good sports psychiatrist interacts with all of them, that we need to be a part of that team. If we're not a part of that team, we're going to be very, very, very stressed to try to be a part of a solution. We'll probably end up being more of a part of the problem if we're not viewed as the team. So thank you for those great points.
The part about the role model, I can't help but think of the other end of that particular statement, where when we talk about athletes as role model, a lot of people look up to them. A lot of people look up to sports, but sports, it's not just a very great unifier. it can divide people very strongly. And when things don't go within expectations for them as a role model, they could receive a lot of backlash, especially on social media. Death threats, comments that are very nasty, or this that not only impact their mental health, it actually impacts people around them also. I'm just thinking it from a different perspective when things goes wrong with them as a role model. The closest example I could think of is the recent FIFA. It's not specifically one athlete, but I'm sure you all know what happened during the prize giving ceremony about a particular chef. The backlash on that chef on social media was horrible. It went all over the place. People were leaving comments and putting things over and over. Those things actually have some mental health consequences. Those things can actually break and cause problems. The reason why I'm thinking about this is because a number of athletes within Malaysia has recently commented that yes, they actually want to inspire people, they actually want to be the role model, but when they don't perform the way the society actually expects them to perform, the backlash that they receive on social media actually affected their mental health, actually affected their performance, actually affected their quality of life. So I just want to highlight that this is
there were death threats. I mean, during the World Cup,
yes,
there were people missed a goal, missed a penalty kick, or I mean, there were, and we see this in the U.S. as well. But FIFA, we just had the World Cup. I mean, it's quite extraordinary in a very negative way how people will, this idea that yes, this is a lot of billions of dollars involved. But let's be honest, at the end of the day, it is entertainment when you get to that level, very high level, and the number of death threats. Because we do a little work with that, is just extraordinary. So you're right, the social media plays a critically important role. My wife coaches high school sports. One of the members of her team, she just found out, quit the team. She didn't even know about it because this girl was being somewhat bullied by other people. So it's a very complex story. And again, I think this is part of the world of psychiatry moving forward. Your generation of psychiatrists will deal with issues that Rachel and I never really had to deal with so much. Social media wasn't a big deal, back in the 70s, 80s, and 90s, during our career, but it's a critical part now. And we need to understand, whether it's with sports and athletes or just in our practices, how to use it as not only a diagnostic, but a therapeutic tool. And Eugene is so right. These are two-edged swords. They can be very helpful and beneficial, but we have to be cautious of the negative impact. And my own personal experience is I've probably seen recently actually more on the negative side with social media than the positive. So it is what it is. We just need to understand it and use it to be for the betterment of our patients. When we consult with primary care physicians, which Rachel and I, that's been a big part of our careers. But how can we help educate and train our primary care colleagues to do a better, more effective job? So how about that how about some questions or comment either in the chat or for those of you who chose to jump on the line today? I'm sure you must have some thoughts or questions or your own experiences or comments.
Actually, I have some thoughts, and I don't after that conversation, I never thought about sports psychiatry because it's not actually relevant in Turkey or in my home country because we don't pay attention to that.
I'm sure you must have some thoughts or questions.
But I have been professional swimmer in my years, and I know that we do sport for actually pleasure or just for get relaxed. But when you're professional, you do sport for actual competition, and you have too strict diet or just so strict program for doing it. And actually, it went from pleasure to stressful even. And actually, I remember that I know like to go to swimming because I know that I have to swim for 3-4 hours without just any. How can I say, without any break, and actually it's too harsh. And I was like, how can I say, 18 years old, but I know that when you go upward, actually you work and you exercise more and more, and it's just get more actually stressful. And I mean, it's like actually too how can I say, controversial topic because now professional sporters don't do sport for entertainment. Actually, they do it for money, or just they do it for fame. I don't know. There are a lot of points on how we can approach them, because actually it's their work that they do it, and if it makes them anxious or maybe depressed, it's like, you know, their jobs that they're doing. It's not like entertainment for them.
Well, it's a good point. So I also was a swimmer, and I swam at a fairly high level myself for the national team. And one of the things I think we could do is bring it back to being a medical student. So we know medical student requires tremendous, or resident, a lot of time. You're studying, time commitment. You know, we are elite students when we're in medical school. Now, listen, we all know that there's some students who are miserable and hate it, and they're probably the ones who, you know, struggle to get through, or maybe just get through long enough to get to their residencies. But there are other students who do that same level who say, yes, I'm working hard, but I enjoy it. I study with my friends. We're doing the best. And when we're feeling down, we're saying, this is going to make me a better doctor. So I think maybe we can't relate to a professional athlete unless you've been there, but we can all relate to that. And people in their work say, you know, that sometimes what allows us to be successful is a little cognitive restructuring. Say, yes, it's hard work. And if you really hate it and you really don't want to do it, then maybe you should be thinking, hey, what is it that you hate? Is it the sport, or is it school, or is there something else? But, you know, as most of us feel, we probably only live one life, or at least that I know of. And it's important to, and that's when we get into the quality of life. And I think you raise a point. You know, I deal with a lot of NFL players in the United States. They make a lot of money, some of them in the hundreds of millions of dollars. And I have some of them said they're miserable. They'll walk away from it and go coach high school football, and they'll still take care of their family because they enjoy it. So our role isn't that we're not counselors telling people what to do. What we want to do as good psychiatrists is help them understand what it is they're feeling, acknowledge their feelings, and then deal with them. Help them come up, not telling them what to do like a high school counselor, but having them understand and then get involved in a healthier lifestyle, as Eugene started off with good sleep, exercise, a proper balance in life. I can tell you, Katie Ledecky, you know, who's a pretty successful swimmer. I work with Michael. I wrote a paper with Michael Phelps many years ago. He was a pretty successful swimmer. He went through a period where he wasn't too happy, but when he was most successful is when he was really enjoying the time with his teammates. And he was spending 4, 5, 6 hours a day in the pool. So this is where I think sports psychiatry, you've really highlighted, it's understanding those unique pressures of being a professional or a national team, or just someone who wants to get there. They're fighting to make that team. That's their goal. You know, they want to run in the Boston Marathon, and I've spent a good deal of time in Istanbul. I mean, the professional basketball league there. I took care of some of those players, you know, who they all wanted to get to the NBA. So our role is to understand what's driving the affect, the behavior, and how can we help that patient? It's an important part, but is this a cover for some other issues? Or is it really the sport, and then we need to help them deal with that, whether we're using CBT or just understanding them? And that is at the essence of a good sports psychiatrist.
Interestingly, what Farhad mentioned, 2 years ago, we actually wrote a paper on this about how medical students are like elite athletes. You do your training day in, day out, repeating, practicing, maybe have some assessment in between, goes in and out. It's exactly the same stuff as what an athlete would do. And then you get assessed towards the very big end of very major exams, much like a major competition. The similarities is there, so much so that we took a resilience training that we were using for athletes. We actually gave it to the medical students to build their resilience so that they could be better cope during the training as, you know, on the way to become doctors. The similarities is markedly uncanny, and we actually managed to do something. Dave, this was the intervention we presented at WPA last year. It was based on this idea. It was based on this idea that there is a lot of similarities between a medical student and a top performing athletes.
For someone in industry, you know, in a high pressure job, if you don't learn to use resilience, you're really looking at a fast track towards burnout. And burnout can be in the way of self-medication, with alcohol, with other drugs, you know, a whole host of behaviors that tend not to be so healthy. So this is where resilience is so critical in sports, but really in any area of life. You think about an investment banker, you know, really any of the high, you know, certainly as medical students and physicians. But I think that's where I think understanding sports psychiatry really allows us to be a more effective clinician when we're dealing with an athlete. Because I can tell you, I've had athletes who've went to very good psychiatrists, but didn't really understand the unique pressures that go along with being either an elite athlete or someone, kind of aspiring to be one. And the doctor did what probably would have worked well for a non-elite. It would just be like if one of you as a medical student went to see someone and talked about the pressures of doing well. And if they they say, well, you're just like a music major, nothing in our being a music major, but understanding the pressures that can be either self-inflicted or inflicted by school, sports, a job, whatever. That's what we need to do, is to understand how that is contributing to dis-ease, and what can we do to help the patient understand and work with them to develop their resilience. And again, I think the primary care model, I mean, again, Rachel and I are a bit biased on this, but there are never going to be enough psychiatrists. So we really need to train medical students who will all be clinicians, and primary care doctors who have the most impact. And Rachel, you could address this. You've been really one of the giants in the field for many years in this area.
I'm sorry, I have to run. Sorry.
Thank you for joining us, though.
Thank you.
So great question. How about some other questions or comments from either on the line or the chat? Because I think one of the things we have to keep working on is trying to engage our audience a bit more so they feel more active learning. Eugene probably has a whole lot more to share, but if we can engage questions or comments, or even challenge, maybe say, I don't see where this is important. That's okay too. We're not going to jump on you. We want to learn together, because a good critical question is one of the best ways to stimulate good learning.
Maybe I can share my points of view. We have a sports medicine department in our faculty, and we have taken several lectures about sports medicine, but none of them was about sports psychiatry, actually, and the mental health of athletes or any other sport makings. I'm sorry. And also, as a medical student, we have never taken a proper lecture or seminar about exercise, how to use exercise as a coping mechanism, coping with stress and other pressures coming with medical faculty as well. So these two things are, I think, a lack of medical education.
And that's what we have to work on, because you ask any good sports medicine doctor, what are the key factors in someone coming back from injury? And it's usually not orthopedic or musculoskeletal. It's and I can tell you, because I've dealt with all levels of athletes, it's the worry about being away from the team. Am I ever going to be able to get back to them? They feel isolated. They sometimes get depressed as a result of not being able to engage in something that's a critically important part of their lives. So to have a sports medicine lecture that doesn't say that, what motivates an athlete, good, bad, or indifferent, to not deal with that is really to do, quite honestly, an inadequate job. And this has been one of the big problems in sports medicine, that, as Eugene said, this was the first Olympics that really they had sports psychiatrists. Even though I've been doing this behind the scenes since 1984, it was never recognized, because athletes thought it was a weakness to have mental, and they were told that you don't show your vulnerability to your opponent. And now we're realizing something different. The idea of not talking about the role of exercise in treatment is really, and I'll be very blunt, is inadequate, because there's robust literature. It's one of the most inexpensive, lowest side effect profiles, effective things you can do compared to really almost anything. And yet to not do that, and that's what we have to, not to scold educators, but to say that this is something this generation of students, if they are committed to being the best doctors they can be as medical educators, we have to make sure that they appreciate this. And to not do that, I think, is doing an inadequate job of preparing clinicians moving forward.
It will be a very big work in progress. And I think in the future, we will be moving more and more towards this particular direction of a certain level of advocacy work. Okay, I do need to excuse myself for a while. I think I need to make a move here. Dave, I will hand it over to you. Yep,
I can start. If there's more questions and comments, like I say, it's it's 1:15 in the morning, and I got to get up at 6 myself. So, but I'm more than happy to stay on for questions or comments that others have, either in the chat or I don't know if Alicia wants to share, doesn't have to, or Sinan, but Eugene, good seeing you. And let's just, if there's any other comments or questions, and if not, we'll knock off and give you an extra 15 minutes to go at least get a good stretch.
Good morning, doctors and colleagues. Sorry, good day. I have a question actually. I'm a medical student from Malaysia, so I attached to my latest attachment is to primary care centers. And I have a question on how do we include exercise when probably counseling or prescribing as a treatment to patients, because from what I noticed, every time the doctor mentions about exercise, the patients start to look stressed. And then I was thinking, if prescribing exercise, how do we prescribe the correct exercise, and would it have a reverse impact instead if prescribed wrongly? Sorry, I don't know how to find the words, but yeah.
Yeah, no, so it's a very good question, and I think I can give you an answer that would be somewhat adequate. First of all, can we ever imagine having a diabetic come in and just tell the patient it's only important to get your right dose of insulin, but and never mention things like diet and stress reduction? I mean, we know that adequate treatment of diabetes or hypertension, chronic diseases, really requires a whole lot more than just the right medications. Stress management, sleep, diet, all those things. So when a patient comes in, if someone had, for example, maybe they had surgery on their shoulder, would we say just take the right level of medications? Or might we say, it's important to maintain range of motion as part of your treatment is to go through, So what we need to do is use analogies that make sense to the patient. Don't say just do exercise. To them, exercise might be doing something they can't stand. It's like going on a diet. Maybe they think a diet means I don't get to eat any of the foods I really enjoy. So what we need to do is explain to the patient, whatever we're trying to treat, that, there were a lot of factors that went into getting to where you are, whether it's a physical illness or we're treating a mental illness, but certainly in the primary care clinic, which means the way to be effective is to address all those things that might help you get better, that will improve your quality of life. And what I say is, sleep, stress management as best we can. We talk about, but then when we talk about exercise, I say, what things can you do when you go out and you're moving around where your heart rate gets up a little bit that really make you happy? And some people say dancing. Some say, well, I like to go for a nice walk, swimming if you have access to the pool, bicycle riding. But what I think is important is not assign them. Remember when I said earlier, it's got to be enjoyable exercise. What do they do that when they go out that increases their heart rate a little bit? Dancing doesn't make a difference. As long as it, I hope they're not getting their heart rate up because they're taking, amphetamines or something. That's not so good. But what type of activity do they do that makes them smile, that they enjoy? And they say, what do you mean, doc? I say, well, going for a nice walk with your children or your significant other, or watching a beautiful sunset, biking, because people tend to equate exercise, unfortunately, sometimes when you say diet. And diet's like punishment. I can't eat the foods I like. I can't have the portions I want to have. So when you have that negative association, then you're going to want to, I'm not so interested in that. We need to understand what motivates it. And you talked about swimming. I remember I went through a period of my career when I just got sick of it. I mean, I didn't want to get near a pool because all I remembered, this was before we wore goggles, was having bleary eyed and my skin smelling like chlorine and my hair, we were 3, 4, 5 hours a day in the pool. And it wasn't until a few years later that I just got back to the joy of getting in the pool and that feeling of just getting that nice long stroke and the quiet and that, so the positive parts of it. So what we need to do is when you're in that primary care clinic, make sure the patient understands that this will improve their health. This isn't about just looking better or losing some weight. This is about improving their heart, their circulation. It has an impact on virtually every type of illness, physical or emotional. And what we need to do is work with them to find something that is enjoyable. Do it 3 or 4 times a week. do it for 20, 30 minutes if they can do that. But if it's fun, they're not going to have to, they're not going to have to work to find, do you ever notice if you love cheesecake, you don't need someone to give you a big excuse to go have a piece of cheesecake, right? If you hate it, they say, well, have a piece of cheesecake, not so, So we need to understand what motivates behavior. Well, the best motivator behavior is reward, not punishment or not negative reinforcement. So in that primary care clinic, I would help the patient to understand why some type of enjoyable movement is good. We go out and go for a walk with your friends, your colleagues. You're in a part of the world where we have warm weather a lot of the time. Go down to the beach. Help them find what really they can have a passion for. And it can be anything. They're not competing. It's amazing to me how the elderly folks I was dealing with when I was in Saba doing their, there's no way they were going to miss their Tai Chi. They loved it. They loved seeing their friends, and they went through for a good hour. They got their workout, they got their range of motion, they sat down, they had a nice cup of tea. So it's got to be enjoyable. And I'm not aware of too many exercises that are a bit over-exercising, doing something that you're not, going out and trying to run a marathon or, to climb Mount, Kitabalu when you're not in shape. That's probably, but something that they can enjoy, that will get their heart rate up, and say something that when you finish, you sit down and say, boy, that was really fun. I enjoyed that. Then they're likely to do it more. So don't just say exercise and leave it at that. You need to explore a little bit and then ask them when they come back, hey, how's that walking going? Can you go out for a bike ride, with your kids or your grandkids or your parents or your grandparents? Help them understand that that type of exercise is every bit as effective as getting on an exercise bike or treadmill that they might despise.
Thank you very much, Dr. Barron. I learned a lot, as usual, and from all of the contributions. I would like to have a question. Some athletes are using steroids here. You have mentioned nutrition and drugs and alcohol. What should we be careful about the steroids?
Yeah, so I can talk a lot about that. So I've been a doping control officer for many, many years. I consult on that for the IO, for the International Olympic Committee. So what we see in sports is, and it's interesting that we see steroids oftentimes in athletes, but there was a time not too many years ago where the use of ADHD drugs, stimulants in medical students, it got to the point they were almost going to start drug testing medical students before they took high stakes exams, because they would take a Ritalin, so they could pull an all-nighter to stay up all night to perform better. So steroids, they're still play somewhat of a role. And you actually have the World Anti-Doping Agency, that's called WADA. And WADA is involved in doping in sports. At every major event, every Olympic event, world champions, professional, they do drug testing. And the point of WADA is that there's a lot of pressure, just like you have a lot of pressure to do well in the exams. So maybe you'll stay up till 2 o'clock in the morning for an exam. You don't want to, you shouldn't, but the pressure is so great that you'll do things that, maybe aren't the most healthy for you. Instead of going out for a nice walk and getting some fresh air and some exercise, maybe you'll sit and study 4 or 5 hours in a day because you've got a big exam coming up. I mean, there's the pressure of the field kind of forces us to do sometimes things that we know probably we don't want to do, but we want to get through. In athletics, and we have a swimmer, I was a swimmer, it's that, you want to be able to keep up with the competition, and this leads to a lot of the burnout that people tend to hate what they're doing. They're doing it and they don't really want to. So the thing with steroids is, and I saw a lot of this in cycling, which at one point was one of the dirtiest sports, the Olympic cyclists. And the reason they were doing it was they knew if you weren't doing it, somebody else was. So you were going to be a competitive disadvantage. So the 3 tenets of doping in sports, anti-doping, is the health and safety of the athlete. So we know that the use of anabolic steroids can have some pretty significant health effects, short-term and long-term, when they do the stacking. They don't take them in physiologic dosages. The fair competition, because it's not fair if someone is taking some chemical then. And then the third is the integrity of sport. Those are the 3 things that WADA is built on. So when we're dealing with athletes, it's very important to educate our athletes that sometimes the pressure comes in the locker room. It's teammates Or sometimes back in the day, it was, it was a trainer that said, yeah, you put on 20 pounds and you're likely to make this team. So what we need to be the voice of reason and health, yet always understanding the pressures. So when we're talking about drug, alcohol, you don't see a whole lot of alcoholics. A lot of athletes will use alcohol to decompress. A lot of the swimmers would go afterwards and, have a couple of beers after a meet. A football player, rugby players, it's notorious. I played rugby. A lot of people play rugby so they can go out and, drink a lot of beer with their teammates and their opponents after the rugby match. So it's important for us to educate about the risks associated with doping and to make sure this is why that it's fair to everyone, because the pressure, I've known people who didn't want to dope, but did it because they felt if they didn't do it, they wouldn't be engaged in their sports anymore. So that's an ongoing issue. It goes back to the early 1970s. 68 were the first games that they started testing. This was in Mexico City. 72 in Munich, a little bit. It really, in the 76 games is when so really ever since then, doping has been a key issue. And I don't know of any professional sport now, maybe other than, some of these MMA and some of the boxing where doping isn't important. And we need to be educated about it because this is an ongoing issue. And particularly, you believe it or not, in adolescents when they're trying to make it up. So it's not just at the professional level. So this is something that I think we could probably have a whole nother session just on doping in sports, but something that we need to be knowledgeable about how to deal with it and about how to educate athletes and teams about the important role of anti-doping and to have fair and clean sport.
Thank you. Thank you very much. Do we have any other questions or comments from our participants?
Just thank you a lot for this information. It's really like, actually, I see that we do a lot of things that we don't like in our daily life, and that's what makes us stressful. For example, we want to do sport, but we do it actually in a wrong way. For example, we went to fitness. Actually, we don't get pleasure from it, but it's like what we see and what taught us. But when you say that, you actually make sport with dancing, you can increase your heart rate even with dancing or just doing other things that you enjoy. It's like, actually it's so simple, but you don't pay attention to these details. That's why it makes the process so depressful and stressful and like actually nothing just unenjoyable.
Yeah, I remember when I was coaching after I stopped competing in medical school and coaching, I coached some pretty high level, Olympic level athletes. And I remember some days they came in, they just tell they were tired. I said, we're going to do something different today. Everything in the pool, you got to swim feet first. Or, or we do something goofy with it because I get them in the water. So they're still sculling, they're still getting the exit, but I had to make it fun. And then we would joke. Like we used to do all night things where we're going to stay up all night. We're going to train. We'd do goofy games because we need to bring that enjoyment. Just think of a medical student. If you never had the time to go out with your friends, maybe study with your friends, if you never had any of that, I think COVID did this. We were so isolated, but yet if you can share it with your colleagues, with your friends, maybe with some of your favorite professors, when you can go out and have a little fun with it, then it makes it tolerable. So, and I think this is, as psychiatrists or as students maybe interested in psychiatry, understanding resilience has a lot to do with enjoyment. And if people feel like they're hopeless and helpless, I'm miserable, I can't stand this sport anymore, but I got to do it because I need to feed my family or it's the only way I'm going to make it on the national team, that's a dangerous place to be. So what we can do as sports psychiatrists is to go in and say, have it be fun. Even studying, it's not always, a lot of ways, but saying, hey, you know what? I'm going to be a good doctor. So this is what sometimes we need to help not only our patients, but our colleagues and ourselves. So sometimes the simplest things are the most effective. Well, thank you all. It's 1 o'clock in the morning here in Los Angeles. I'm going to go to bed and I look forward to seeing all of you next month. And thank you for taking time from your schedules. Take care. Have a great day.
Yeah.